Good morning, Vimal. Can you hear me?
Hi, good morning. Yeah, I can hear you, Girish. You can hear me?
Yeah, very well. Tell me.
Okay. Do you see the screen there?
No, I see only you and Diptiman. Hi, Diptiman.
Okay.
How are you?
I think we'll...
Fine, sir. Good morning, sir.
Okay, so let us know about this case. What are you going to...
First of all, I want to... my friends there, we had a good time last, Thursday evening when we had the quiz and the dance. I hope my dance partners are all there sitting in the audience.
Yeah, they're all there. Don't worry.
They are there. Okay, great. So, we are here at Kokilaben Ambani Hospital in Mumbai. And we have Dr. Diptiman, Dr. Gordon, Mr. Praveen, who is our technologist, and my nursing staff. We are showing you a very interesting case here. Though it sounds or looks little simple, but the case is really very interesting. This is a non-diabetic 57-year-old male, and he's a smoker. He came this time with claudication pain in the right gluteal region and the upper thigh. Now his claudication distance was just about 150 meters, which was restricting his lifestyle also. What is important is to note that in 2013 I had done a iliac angioplasty and stenting for class D lesion involving bilateral common and external iliac artery. This time when I examined him, I felt the right femoral pulse was absent. And I immediately took him up for a CT scan. In view of the stent in place, iliac arteries, ultrasound is not a good choice. So CT angiography was done. Can I see the CT pictures, please? Good. Now here I will first take you to 2013 images. As you can see, bilateral iliac arteries are diseased here. Next, it's an interesting case last time also. The left external iliac artery is totally occluded and you can see the internal iliac artery. Next, we tried to do a retrograde puncture from the left side, and you can see that I am trying to get a stiff end of the terumo across the CTO and the external iliac artery on the left side. We came up to the upper level, but we could not go completely. So then, as you can see, I have also come from the crossover, and there the catheter, we are making an injection. There is a distance between the two. So we started doing catheterization from the opposite side. And next, keep on going next. Yeah, there you can see that I'm struggling. Finally, I could get my micro catheter. That's a pro-grade catheter. And there you can see that I could cross it. And I confirmed it by injecting into the distal common femoral artery. Once that was confirmed, I put a wire across and got it out into the sheath on the left side. And I externalized the wire there so that I could do my whole procedure from the left side. Next, there you can see that I have gone across and we are balloon dilating the segment, pre-dilatation. Next, as the dilatation is happening, can you hear me, Girish? I have lost you, Girish. Hello?
We can hear you.
Girish, can you hear me? Yeah, okay. So we did a pre-dilatation first on the left side. We did it on the right side also. And next, we then got the two wires both from the femoral artery going into the aorta. Next. Next. There you can see the injections that we are making to confirm we are in the aorta now. Yes, next. There the two wires are there. Next. After the pre-dilatation, now we are getting the stents. These were self-expanding long stents that we needed. There you see bilateral common iliac segment, we have stented it. Next. Now we have got long stent coming from the previous stents down into the external iliac artery. We wanted to keep the stent above the joints. The common femoral artery looked quite healthy, so we didn't want to go across. As Girish mentioned, stents across the joint could cause problems in a later long-term follow-up. Now here you can see we went for a post-dilatation and there is a big rupture there. So immediately next, we just tamponaded with the balloon and got the covered stent here. So this was a fluency covered stent that we put it across and dilated it again. There the lumen is okay, now there is no leak. Next. We then went across onto the right side also and put in a stent there. This was confirmed, left side is okay. Right side is also looking healthy. We have now put two stents on both the sides and covered it up completely. You can see the contrast which was leaked, shifting the bladder a little bit. Patient was absolutely stable because we had done the tamponade. So this was what was done. Can I last further go ahead? No, this was the last. Yeah, somewhere there was an interesting thing that has happened. Gordon, can you just show the last piece, what happened then? You know where the stent was, next, last. I think it was the last slide. Something more? Yeah? Oh, okay. Where the wire was coming out, Gordon, that is what I wanted to show. So there was a wire which I had put in from the right side going to the left. And we withdrew the wire from there. And patient was doing extremely well so far on a dual antiplatelet. I think one antihypertensive that he was taking and statin. This time when he came again with a claudication, we got a CT scan done. Can we see the latest CT scan? There the latest CT scan, as you can see that the reconstructed image looks nice and good and you don't see anything. But when you look at the, now go back. Yeah. See that on the CT scan you can see the upper end of the right stent has crumpled and there is a filling defect within. This is probably the cause for the claudication that the patient has. Rest of the iliac arteries, as you can see, they look very nice and good. Next. This is now, look at this CT plate. There is a kind of crescent-like defect in the left, in the right stent, just as it is at the bifurcation. And the next slide, you can see that there is a nice filling defect with the in-stent stenosis. Next. So our plan was to do bilateral femoral puncture and put a 8 French sheath on the right side from where I plan to put a stent there. And on the left side 7 French sheath because I want to keep a balloon there. The right side stenosis I want to go with a terumo wire and cross the lesion. I will show you this, how we have done this. We pre-dilated it first and now we are doing the stenting again. I will just show you what we have done in the morning so you will get the idea. Here you can see on the screen, I suppose the screen is there with you.
Yeah, we can see.
So this is a puncture and I have just got a wire across. This is a terumo wire, curved terumo wire 035. And you can see that as the wire is going up, it is going very smoothly. And it went across the crumpled portion up smoothly. And that the crumple, you can appreciate that very well. I first thought that probably my opposite stent is compressing on this particular right-sided stent, but that's not the case. There is a gap between the two. And so now I've got a wire across. Can we go ahead with all the pictures? There you can see that the crumpled stent next. There I've got a catheter from the left side making a contrast injection in the aorta. You can see the narrowing in the proximal right common femoral, right common iliac artery. The rest of the artery looks healthy. Next. There you can now see both the wires across. And now I'm trying to get a balloon across on this side. Girish, you can see that the balloon is not going up.
Yeah, but did you think of, because you had seen on CT that there was a kind of a thrombus, did you think of doing a suction thrombectomy or something like that?
No, this was a chronic issue for a long time. He's got this for last 6 months. He's following up. So I didn't expect this to be a thrombus.
Okay.
But this was just not going up. Girish, what would you suggest to do?
If this balloon is not going...
See, the balloon is not going up.
Correct. I would change over to maybe a coronary wire and use a smaller coronary or a peripheral balloon to create a space.
You know what? I felt this was probably going through the strut. If you see the first picture, the wire had gone up straight.
Correct.
Yeah.
So I said I need to make a loop of the wire and then go up.
Okay.
So next. So it was still not going. Then I got the wire down. I was placing the catheter balloon on the other side just to support it there. Now you can see it has gone up. Did you show the wire going up? You know, we withdrew that first wire. Oh, I have not recorded that. Just see that. We pulled out the wire. As you can see that Diptiman is manipulating the wire there. There was a hold up there. And then we could go forming a loop. We went up there. So the loop helped us to go through the true lumen rather than through the struts. There the loop was. Did you see that loop?
Yeah.
Once that was there, our wire balloon went up straight very easily. And now I will just show you the actual case now. Can I have the flush? So now what we are doing now is both the wires are in place. How we went up I have shown you. And we will now get the, we did a pre-dilatation also. Can we show that also? Once the balloons were up there, we pre-dilated the segment. Next. There the balloon is coming up on the right side. It's gone up. Both the balloons are now kissing each other. We've got a 6 mm on the right side and 8 mm on the left side. Left side is not under high pressure. So all that now done, the bed is ready for getting our stent. We thought of putting a balloon mounted stent here because we wanted some more strength here. We needed a small length of the stent. We did not need a too long. So you can just see that I'm just getting it slightly above my previous stent. And I'm getting this balloon also in place now. Isko inflate kar. I will just, with a low pressure, I will inflate the left side so that I don't want anything to shift on to the opposite side. Okay. Now I will place this precisely. I have the marker of my previous stent. I will just go up on that. This is a 9 mm into 27 mm Myra stent. I will just show you the, can we inflate it? This is the stent being inflated now. The nominal pressure is, kitna hai? 7. 7 atmospheres. So that is my stent being inflated. This is how many? Yeah, we have reached the maximum pressure now. I think we are okay with that. Deflate the balloon. And with this, I'm probably opening up the previous stent. I only hope I have not gone too high up on that to cover up the opposite side. I don't think so it will happen because the previous stent will hold it back. Okay. I think we can withdraw the previous stent, the right-sided balloon. There it is. Catheter diagnostic.
Vimal, we have a simultaneous case going on from Pune. So what we'll do,
yes,
most of it you've done now. So we'll come back to you in a short while. Yeah, Vimal, we are back.
Yeah, Girish. Okay. So as you saw, we finished the balloon dilatation with a balloon mounted stent there. We used the Myra stent there. 9 into 27. We kept at least 2 or 3 struts above the previous stent just to see that it does not come back. And once that was dilated, as you can see, we did the kissing technique again so that we don't want anything to happen to the left side also.
Correct. We saw this.
So that you saw this. Next. We are now taking the angiogram now. Next. Without the wire. Basically, I didn't want the wire to see whether the stent is falling or no. I think this picture looks good.
Very good.
Yeah, it looks good.
And but on the way we realized there was a slight narrowing in the left side stent also lower down, where probably we have got the fluency also.
Correct.
My 7 front sheath was causing partial occlusion there. So that also gave me an idea. So I went in next.
That's where the covers.
Yeah.
There you can see that I just dilated it with a 6 mm balloon. Got that dilated next. And once we saw the picture, it all looks good now. The pulse in the right lower limb is now bounding in the dorsalis pedis and PTA. And if you can see that next, I wanted to see the contour of the stent. Now you can see that upper ends look okay. The right one is not covering the left. There is a good gap between the two.
But tell me,
and the previous one has expanded the.
What do you think the cause of that crumpling of the stent was? Any idea?
Yeah, okay. So I will show you that. I will just show you, Girish, the exact thing what happened. The Gordon will show you there on the screen. There you will see it.
Yes, we can see that. last time.
Okay, now you can see that from the right side we had gone to the left side
Correct.
with a balloon when the rupture took place.
Correct.
And then as you see that, look at that now, as the wire is being pulled out and the balloon is being pulled out,
Okay.
probably it was the, yeah.
Yeah, right. We can
So
see
it was
that now.
the, probably the balloon which was inflated previously has lost its profile and probably caught on to the stent strut. And as you can see now it has crumpled and the distance between the two has widened.
Right.
Okay.
So that was the process and that must have initiated instant stenosis and the symptoms, and therefore we went ahead and did this.
Okay, excellent case.
So few things not to do and few things to do.
Yeah.
But I don't think you had too much of an option there, you know. At that
Yes.
point when you had that rupture, you had no other alternative.
Yes. So
Unless
these
you
things
came from
could
the
be
break-in.
avoided, could be, yeah, yes. So this is what has happened and finally we have corrected it. I think symptomatically he will tell me tomorrow. I think you can go back to Pune or you have questions, I will
Okay.
answer them.
Any questions from the audience? Okay, I think that was a great case,
Yes.
great
Myra
learning
ka dabba
case.
dikha.
Thank you very much, Vimal.
Photo dikha.
Well done.
Great, thank you very much and all the best to all my friends there.
Thank you.
Thank you. Thank you very much, Vimal.
Yeah.
From Kokilaben and my colleagues from Kokilaben, Cath Lab.
Thank you.